My name is Daniel Cavazos. I'm a third-year orthopedic surgery resident here at the Detroit Medical Center. This is my poster for the DMC QUESST Research Day competition. The title of my project is Predicting Factors for Blood Transfusion in Primary Total Knee Arthroplasty Using a Machine Learning Method. This project was performed in the Department of Orthopedic Surgery at DMC in addition to the Department of Biomedical Engineering at Wayne State University. To start, allogenic blood transfusions continues to be a common postoperative complication in total joint arthroplasty. While transfusion rates have decreased with advancements in technique, better clinical guidelines, transfusion thresholds, and the usage of tranexamic acid, or TXA, there continues to be a high rate of transfusion with as high as 11% in total knee arthroplasty and 15.9% in total hip arthroplasty. It is known that allogenic blood transfusions are associated with extended hospital stays, postoperative infections, mortality, thromboembolic events, and increased resource utilization. The goal of the study was to perform both a conventional statistical analysis in addition to a machine learning analysis to predict factors associated with transfusion in total joint arthroplasty. In terms of the methodology, this was a retrospective review of level 3 evidence. 2,093 patients underwent primary total knee arthroplasty at the Detroit Medical Center between 2016 and 2022. There were two cohorts. There was the blood transfusion versus the non-transfusion. The SPSS statistical software was used for both the conventional statistics and the machine learning model. Our model for the multi-layer perceptron neural network, or the MPNN model, had an area under the curve of 0.894, with good models having areas under the curve greater than 0.8 for our model validation. In terms of the demographic table, you can see the demographics on the left-hand side. With the two groups, blood transfusion versus non-transfusion, there were 67 transfusions and 2,026 non-transfusions. In terms of variables that were statistically significant, age was greater in the transfusion group at 65 versus 59 in the non-transfusion group. The transfusion group had a higher ASA score of 2.96 versus 2.7, and the smoking status of the two groups was statistically significant. In terms of actual surgical variables in the second table below, you can see the surgical variables on the left-hand side and the two groups, transfusion versus non-transfusion. Surgery type was significantly different between the two groups. Conventional total knee arthroplasty had a rate of blood transfusion of 3.9%, which was higher than a robotic-assisted total knee arthroplasty at 1.9%. Simultaneous bilateral surgery was approaching significance with a p-value of 0.54, but was not significant as a Fisher exact test was used, as there was only an N of 2 for transfusions. Preoperative hemoglobin was lower in the transfusion group at 11.59 versus 13.49 in the non-transfusion group. The postoperative hemoglobin was inherently lower in the transfusion group at 6.72 versus the non-transfusion group at 10.19. Preoperative albumin was approaching significance at 0.057 but was not significant. Preoperative creatinine was significantly higher in the transfusion group at 1.53 versus 0.91 in the non-transfusion group. Length of surgery was approaching significance, but was not at 1.63 hours in the transfusion group versus 1.54 in the non-transfusion group. Preoperative TXA was significantly higher in the non-transfusion group than the transfusion group. And then lastly, the patients who underwent a transfusion had a significantly higher anticoagulation use than the non-transfusion group. In terms of our MPNN model, it takes multiple variables on the left-hand side there and searches for multiple pathways or associations that ultimately predict whether there's a transfusion or a non-transfusion. 70% of our data was used to create this model, and then 30% of the data was used to train or validate the model, which ultimately yielded our area under the curve of 0.894. This model then ranked risk factors for blood transfusion for their normalized importance. The values were preoperative hemoglobin at the top, followed by pre-op creatinine, length of surgery, simultaneous bilateral, TXA usage, ASA score, pre-op albumin, alcohol usage, anticoagulation, age, and surgery type. Postoperative hemoglobin was excluded from this analysis, as this does not help predict the risk for a transfusion prior to surgery. The power of this machine learning tool is that compared to traditional statistics, which just says whether or not there is a significant association, it actually attempts to rank these factors for their importance. This is a powerful tool in the preoperative planning for surgery when you're deciding whether a patient should undergo a primary total knee arthroplasty in an inpatient versus an outpatient setting. These patients with high risk factors for blood transfusion would be better off in an inpatient hospital setting where there are more resources available for possible transfusion and the following sequelae following that. The limitations of this model is that one, while it ranks the importance of these variables, it doesn't provide any sort of cutoff or threshold value for transfusion requirements. And secondly, it's sort of the black box nature of the MPNN model is it takes multiple associations and variables in this sort of black box way, and you're not really sure what all of the associations are that ultimately lead to a blood transfusion versus a non-blood transfusion. To conclude, overall, we did see agreement between both the traditional statistical analysis and the machine learning model. The machine learning model was able to rank these risk factors in terms of their normalized importance. And this is a powerful tool in preoperative planning for the total joint arthroplasty surgeon in planning where the surgery should be performed in addition to reducing costs in these procedures.